Professor and Clinical Education Coordinator for the Professional Athletic Training Program at Indiana State University. Dr. Gaven has experience as both a patient and clinician treating patients with post-concussion syndrome with the utilization of vestibular rehabilitation. Ladies and gentlemen, please welcome Dr. Stacey Gaven to Spats.
Perfect. All right, thank you. I'd like to thank Spats for inviting me to come down here and speak to you this morning. I'm really excited. I will have you doing some involvement. So you guys are going to do some vestibular rehab today. So as we get towards the later part of this presentation. So if you could prepare by taking out a business card. So if you have one of your own or if you've picked one up from one of the vendors, that would be great. If not, if you have anything else that has lettering on it, if you have a water bottle that has a label on it, that would also be useful. And then I do have a limited number of business cards that you guys can utilize. When we get to that point, I'll bring them up front and you can take one if you need one. And so today, I just have to let you know I have no conflict. The views here are my own unless otherwise noted by research, so I bring a lot of research into the presentation, and that the information I'm presenting to you, I ask you to use at your discretion with your patients. So I have four main objectives here today as we talk about vestibular rehab, and one is to understand the need to further evaluate some of our patients, especially those who have persistent dizziness, maybe are talking to you about balance problems, or just not recovering as quickly as we may expect. Some of these individuals may really be those that would benefit from vestibular rehab. The other is to look at the recommendation of the benefits that vestibular rehab may have for some of our patients. How has the effectiveness been shown? And then we're going to actually do some vestibular rehab because I want to give you the tools to take back to your patients and implement this with them. And so I'm going to just kind of start with going through my own journey of concussion and how I got involved with vestibular rehab. I suffered 3 concussions my freshman year in high school, 1 in each season of the sports that I played. And then I was good until my senior year in soccer where I suffered my 4th concussion. And this was the first time with a concussion that I didn't really recover very quickly. I had some short-term memory issues that lingered for a couple of days, and my symptoms just tended to stick around a little longer. During my collegiate soccer career, I did not suffer any concussions. But in my post-collegiate career, I had a semi-professional career, I suffered 4 concussions. And with each, except for one of the concussions, they were accompanied by another injury. So in my mind, I was just taking longer to recover because I had these other injuries confounded with the concussion. In reality, I was taking longer to recover because I've had a history, and really there were probably things that weren't fully healed or fully approached in some of my concussions as I was moving forward. But even with the education I had, I convinced myself that I was just taking longer to recover because of these other injuries. So because of this, my last concussion in playing soccer, my 8th one, I had symptoms for over 2 years. And that's really where I got involved in learning about vestibular rehab. I decided that at this time it would be a great idea to go back to school and pursue my doctorate degree. And so I'm having all these concussion symptoms, I'm having headaches every day, I'm just not feeling right, and I decided to go put a more cognitive load onto the brain. Not the best decision. So in my first semester of graduate studies for my doctorate, I was doing what I called napping. It took me so much longer to do work. I was going back to school after working clinically for 4 years. I was teaching at the college level and really teaching for the first time ever, so trying to figure out and map out that world. And I was basically napping and not really sleeping at night because it took me so much longer to do things. So I would do work as long as I could, and then I would sleep for a few hours, and I'd get up, and so I would be ready for the next day. I would go and prepare and do some more work and maybe sleep for a few more hours and then go about my day. So I had a lot of other confounding factors. And that was at the point where I confided in some of my classmates that, hey, I'm having a really hard time, I'm really struggling. And that's where I saw a concussion specialist down in Virginia Beach, where I was studying at Old Dominion. And that is where they said, I think you do really well with vestibular rehab. And I said, okay, I'll give anything a shot at this point. What is vestibular rehab? And So I went and I got to experience it. And then I realized that this is something as athletic trainers we really need to know about, because we have a lot of patients out there that could probably really benefit from this. And so what I'm finding in the patients that I treat is that they have this struggle that all of our assessments, our initial assessment, our follow-up assessments that we do with our patients after they suffer concussion really isn't capturing some of these things. And they feel isolated because a lot of times, right, initially, and we're moving forward a little bit differently in the research right now, but we cocoon them. We tell them, you're not going to come to school for a couple of days, you can't go to sport practices, you can't go and watch the game, you can't watch TV, no electronics, no nothing. You're just going to stay and rest in a dark room, quiet. So we take everything that's their normal and we take it away from them. And they feel awful at the same time. So to some, right, when I talk to my patients, they feel like they're being punished for having a concussion because of all these things that they can't do. But they need some type of outlet. So they feel that they're isolated. A lot of our patients that we deal with, they're athletes, so they're competitors. They don't want to be on the sideline. We have those few, right, who they would rather be on the sideline than in the game. But for the most part, they don't want to be on the sideline. They want to be out there playing. So they're going to try to figure out what is the quickest way to try to get me back out onto the field, and may not be totally forthcoming to you with how they are truly feeling. So we have to be aware of that and know that the more we can kind of feed their competitive spirit, but in a safe way as they're healing from their concussion, we may produce some better outcomes. A lot of times they feel they've hit a wall, that there's nothing else they can do. They still have these daily headaches. They're still not allowed to do a lot of these things they want to do, so they kind of feel stuck. Or maybe they've had symptoms for 2 weeks now, and to them, they just feel, okay, this is my new normal. And how do I move forward with this new normal? And we really have to try to pull some of these things out, because they feel at times that it's going in a downward spiral. They're not feeling better. They're doing all the things they've been asked to do. They're doing all this, and nothing's changing. And they want to get back to sport, and they just can't get there. And so we see that sometimes they go into a state of depression, and yet they don't want to fully admit that, hey, I'm really struggling at this aspect as well. So some of the things that we need to pull out that our assessments don't really do, and their everyday life struggles. So here I have a picture of a supermarket where everything looks super blurry. And if you talk to some of these patients, so at the high school population, I would always get, I don't feel good when I'm switching classes. So the busyness of the hallway, all the other students walking at them, who knows what colors they're wearing at school that day. So you have a bunch of different colors, different patterns, right? We're bringing back the 80s. We're getting fluorescence back. So all those things give a lot of visual stimuli to the patient. But also, too, now they have to move and be more aware and react. If I walk in a hallway empty by myself, there's not a bunch of different things I need to try to navigate. I can really get from point A to point B without too much trouble. But now I fill a hallway with a bunch of other kids, who's yelling, who's pushing who, all these different things that might trigger some symptoms. Or if they go out, maybe they're just hanging out at the mall with their friends, and they're going shopping, and they're looking side to side at their racks, or looking at different things. That sometimes triggers symptoms. What I get in some of my collegiate patients is that they had to run to the local store to pick up some food for their apartment, and they had to leave because looking and all the, right, if a store is nicely kept, all the labels are facing the same direction. You have a lot of different color patterns that are going on. And if I need soup that's on this side, but I need canned vegetables on this side, I need to be moving my head back and forth side to side as I try to navigate. And so we're seeing some symptoms there. Busier times, so in the common halls where they have the cafeteria, we see that sometimes there, as well as if they have been cleared to drive and it's kind of further along in their concussion, but maybe they're still having some minor symptoms or things that aren't really making sense to them when they are driving. So when you're at a stop sign, you should look both ways, right, and more than just once. And so sometimes that triggers them. Or just at night, the lights from the other cars coming at them. So getting an understanding beyond the things that we would normally look at in some of the questions that we would do. And so that's where I really encourage you to look beyond the playing field. We know that if we have them do physical activity, if we have them do some of that, yes, that would absolutely exacerbate their symptoms. But how are they doing in school? How are they doing with their schoolwork? Is there a certain point in the day that their symptoms get worse? And maybe it's not just because that class is their least favorite subject. It may be because of where they sit in the classroom, how much they have to move their head up and down. How does the teacher present? Does the teacher present with a PowerPoint presentation or a lot of different bright colors or that? Or are they using a smartboard, or are they using a whiteboard? How is the presentation of material going? What happens when they're in outside environments? So their usual everyday tasks that we take for granted that maybe not be bothersome to them, they have some issues. Are they feeling slower? Do they just feel like, hey, everything just kind of feels like it's moving a lot quicker past me than how I can necessarily react to it? Are they having problems remembering things? So whether it's the simple things, do they find themselves writing more notes? Do they find themselves putting more notes into their phone so that they have some more reminders than what they're used to? And the last picture on the bottom represents different patterns. When you go to hotels, when you go to a lot of conference centers, you have carpets and things on the wall and all these busy patterns, and a lot of that times that's a lot of visual stimuli for those individuals. So sometimes when they're in those type of environments, they become more symptomatic because they just can't handle and process all of that. So when we can recognize things beyond what our initial assessments and that tell us, we are going to paint a better picture for our patients. And so what we see here is that we have to address all of the systems that may be involved or affected by a concussion. So it's more than just asking the symptom checklist and maybe doing some of your neurocognitive imbalance testing. We have to find out about these other things. Vestibular function, looking at the cranial, how the cranial nerves are reacting, as well as our oculomotor and balance assessments are really key for best practices. Those are going to encompass all the different aspects that may be associated with a concussion and help you in the management of these patients. And we all know that not every concussion, just like not every injury, is going to present the same way. So we have to look at each case on an individual basis, because what may work for one of our patients is not necessarily going to work for our others. And so we have some tools in our toolbox, and during that initial assessment, you may use some of these. So I know we're not on the SCAT-3 anymore, we're on SCAT-5, but this is the picture I have up. So you may use a SCAT form, and that's going to look at different things. It's going to have our symptom checklist, it's going to look at memory, it's going to ask them some other things. It has the Glasgow-Coma scale. So it incorporates various things. You may do some balance testing with them, so you may do the best with them. And maybe you're using the King David on the sideline or in your clinic, as well as assessing cranial nerves. So those are all great initial assessments that you may go ahead and utilize. And a lot of times, this is what individuals are doing in their follow-up assessments. But when we do our follow-up assessments, we have to look a little bit deeper and know a little bit more, especially if our patients are coming in with certain complaints. So if they are complaining that they are dizzy, that they feel that they're off balance, that they don't feel exactly too sturdy when they're walking and that, we have to look to expand our toolbox. So in our follow-up assessment, yes, we're still going to do our symptom checklist because it's going to allow us to compare how they were initially and how they are progressing. And it can answer a lot of things for us. But I would really encourage you to look at some other things, and maybe some of you are implementing some of these already. So impact and any type of neurocognitive testing, I'm not here to push impact or anything, but you're probably using some type of neurocognitive testing, which again can provide us some more insight than just our symptom checklist alone. But then there's also some other tools. One is the known as the VOMS, so the Vestibular Ocular Motor Screening. And that there is a really good place for us to look and to try to see how the vestibular and ocular motor symptoms may have been affected by concussion. Now, the VOMS is not designed to be administered right away, sideline concussion, because you're going to make the patient more symptomatic, and they're probably going to have increase in scores, and you're not going to necessarily get the best outcome with that. This is down the line. Maybe your patient's telling you, when I read, when I try to do schoolwork, when I walk around, I feel unstable. If I move my head real fast, I feel like things need to catch up. That is when you would do your VOMs. And so that is going to be a really good key for you. And at the end of this presentation, I've included how to do the VOMs for you. So if you haven't been exposed to that before, you could go ahead and see that. Another one would be the dizziness handicap inventory, and this looks at 3 different aspects. It looks at the physical aspect, the emotional aspect, and the functional aspect about how their patient's dizziness is affecting them. So if you have a patient who has persistent dizziness following their concussion, this would be a really good scale to go ahead and give them so you could have a better idea exactly how their dizziness is affecting them across these 3 cognizants, because we know that we can't just look at the physical when we are dealing with injury. We have to look at the patient as a whole. Another one you may consider is the activity-specific balance confidence scale. And so again, if your patient is just telling, I feel really off balance when I'm doing this, this is going to ask them about a bunch of different activities that they're doing and to rank their confidence. So this is a percentage. So 0%, they have absolutely no confidence, to, again, that 100% where they feel fully confident that they could go ahead and do that task and not feel off balance. So these are things that could help shape how we are moving forward and bringing our patients back. Because, yeah, as the previous presenter asked you, do you have a concussion return to play protocol? You guys do in the state of Texas, and it's a lot of times in a lot of states, the concussion return to play protocol is 5 different steps of graded, right, increasing activity. But we never approach all these different things that may be deficits to this patient to make them stronger to approach that. So it would be like taking somebody with an ankle sprain and never doing any type of strengthening or any type of balancing activities with them, and just putting them after 7 days, you feel that they're ready because it's been 7 days, putting them right back in the sport, but not trying to increase any of the deficits that their injury caused. So looking at some of these and trying to implement some of them may give you some better insight to your patients who have suffered a concussion. Another test that you may see a patient referred out for is a sensory organization test. So this is looks at 4 different factors, really. It looks at their ability to maintain their balance in 6 different conditions. You can see in the lower right the different conditions. And so in the first 3 conditions, the surface on which they stand is a force plate. And so that force plate remains fixed, meaning it doesn't move. They may have their eyes open, their eyes closed, or in the last one, what they're looking at, the platform they are looking at from them will move. So it will require the body to react to how the platform is moving. In the other 3, it's looking at a sway reference, meaning that the force plate they are standing on is also going to move as they move. So if they go ahead and close their eyes and they start to become off balance, that force plate is going to react with that. And so what the patient needs to do is to try to maintain that neutral balance as best as possible. So it looks at, do they prefer to use their somatosensory system, their visual system, their vestibular system, or do they really rely on their vision? So meaning that even if the information that is coming through their eyes isn't correct, they're still trying to process that as their way of balancing. So this is just a more in-depth look at some ways of some of your patients who are having a lot of balance issues, dizziness issues, that they may look at to try to get a better profile as to what system they are having deficits in. So if you see here, all the green means that is good. They have hit the standard basically for what they should be doing for their age. And then you'll see the gray boxes, and that is where the norms are. So if they're above the norms, they're going to be in that green, and you can see some of them have below that gray, so they're going to be in the red. And then when you look at the overall sensory analysis, you can see that this individual, their deficit is coming from their vestibular system. So it allows you to hone in on that a little bit more on your rehab of your patient, but it's also a way of assessing progress over time. So if you start this process with a patient, and this is their physician or physical therapist may have ordered this screening, and then you work with them for a few weeks and they want to retest them, this is a way of tracking progress over time, as well as some of those other tools we just mentioned. It allows us to track some of their progress over time. So it allows us to say, okay, the clinical decisions we've been making for our patients have been positive, have been showing a change, we're in the right direction. Or things aren't really changing, I need to relook at things and probably change a little bit how I am treating my patient. And so overall, we have, this is one of my favorite graphs because it's looking at our postural control. And so it comes from really, our ability to take what our eyes are seeing and appropriately use that information, as well as our vestibular system working with us, our proprioception, and our ability to sense touch. So all of those things together send information to our central nervous system, which then goes ahead and tells our body how to react for us to be able to have postural control. So if we have a patient who has decreased balance after a concussion, we need to make sure we're looking at all these systems so when they go out back to the playing field, they have the best ability to perform at their highest level and to perform safely as well. And as we start to talk about some of the exercise and some of the other things, we'll bring in some sport-specific examples. But if you think about it in the sense of, if I have an individual who I'm working with, a patient I'm working with, and every time they go and they turn their head to look up, they have symptoms. If they're a wide receiver on a football team, that's an issue. How am I going to work with that to try to help them? Because if they can't do what they need to do on the field, we're going to have some problems. So we need to look at some of these things more than just what we are in some cases right now. So a lot of times what we're seeing is dizziness is one of the biggest culprits in seeing the patients that need or would benefit from vestibular rehab. So when you are talking to your patients, if they really have that persistent dizziness or they're feeling off balance and it's going on, those are the people we try to capture a little bit more. So normally 3 to 7 days following concussion, our balance should start to improve. And what we're finding in the vestibular impairment is all those words I have highlighted in red. Those type of reportings from the patients are those who we have found to benefit most from this type of rehabilitation. Like I said, not every single one of your concussion patients is going to fit this kind of this protocol that we would look at, but the dizziness, the unstable vision, they kind of just feel like they can't balance. Those are the things that we really want to look for. If they have difficulty focusing in a busy environment, so they're changing classes, or maybe they're in a really big class and they sit up top or they sit on the bottom, maybe it's a theater type lecture, or those are the things that we want to go ahead and look at. And even though we're getting better, and that's awesome because we're moving forward, we still don't see this utilized as much as it should in the sports realm. So when we have patients, a lot of times you hear vestibular rehab, and if you go to a physical therapy clinic where they do a lot of vestibular rehab, a lot of times you're going to see a lot of elderly individuals who are fall risks. And that's where a lot of that stuff really comes from, and that's why we don't really see it as much. But it's something that's emerging and important. And so this comes to the clinical question that we're going to look at today, and it's, can the use of vestibular rehabilitation reduce symptoms, dizziness, and improve balance function in individuals with lingering concussion symptoms? And so I wouldn't be here today if the answer wasn't yes, okay? But let's look at some of the literature that supports this. We've seen improvements in dizziness and overall balance in people following head injury. We know that we've seen these positive changes in both adolescents and adults. So we're seeing the change over both of these individuals, which is great, showing that it's effective for more than just one population. Those with the persistent dizziness, gait and balance dysfunction, we're seeing them have improvements after vestibular rehab. So again, trying to paint a picture of some of the patients that you have that may benefit from it. We're seeing that after 6 to 8 weeks, that dizziness has been reduced. Their perception of their balance function has increased. So if you look back to those additional toolboxes, if you look at the the balance confidence scale, that would help you out. And then the vestibulo-ocular reflex function. So that is your ability to maintain focus on an object, a letter, or whatever it may be while your head is moving. So that is your VOR, and we're seeing increased functions in that. We're seeing it in the military individuals have seen positive outcomes from vestibular rehab. There was a specific study that looked at individuals, so in young adults about 12 to 13 years of age, and they did vestibular rehab with them in conjunction with treating them for some cervical dysfunction that they had as a result of their concussion, and they were 4 times more likely to be cleared to return to sport than those who were just given rest alone. So we were finding those deficits, we were approaching those deficits in our rehab, and we were having positive outcomes. When we look at this overall, areas that we're finding that our patients need the most help in, it's eye-head coordination. You'll see a lot of the exercises that we will do will focus on eye-head coordination, standing static balance, and ambulation. So sometimes you don't really think about, okay, ambulation, yes, if I have somebody who has a knee injury and has been non-weight bearing and now I'm bringing them back, I'll do some gait training with them. Well, what kind of gait training am I going to do with an individual coming back from a concussion? And we'll talk about and do some of those things today. Those that we're seeing that are most utilized in vestibular rehab is gaze stabilization in both sitting and standing positions. And that's really important because when we are implementing this with our patients, you're going to start them in a seated position, and then part of your progression is getting them to stand up, then getting them to be in a wide base of support to a narrow base of support, to being in a tandem stance, to using some type of unstable surface. So we have a lot of different things. And then we also will see doing some walking exercises, so trying to put all these things together. We're finding mounting evidence that when we address vestibular, oculomotor, and sometimes with the use of some pharmacological aids, that we're getting better outcomes in our patients who have suffered a concussion. And really the pharmacological aids are not us using pain relievers, but yet there's been some studies out there showing that the use of low-level antidepressants have been able to stop the daily headache cycle for some of the individuals. So that may be something that your patients may benefit from, or you may have a patient who has been prescribed that and you didn't really understand what was the physician's thinking behind it, and that is what it was. So having that conversation with your patients is really important. The physicians that you're working with to help treat them is trying to find all the best ways to treat individuals. And so we're going to do some exercises together, but before we, and this is where I like to focus on more, because I find it's beneficial for you to have these tools to bring back to your clinical settings and to do with your patients. So going through some of them and having an understanding, asking questions as we do them, as opposed to just hearing me constantly talk about things. So if anybody needs a business card, if you do not have a business card, I do have a stack of business cards that you are more than welcome. I'll come bring them up, so feel free to come on up. And then if we run out of business cards, you guys can also take a tongue depressor. It has a letter on it. And so I'll leave these up here. Just feel free to come up if you do not have a business card or something that you can utilize as we go together. And for some of the exercises, I will ask for some participants, and I'm really excited to see this room has some areas that we can really go ahead and move around in. And so the nice thing about, I'll let everybody kind of get their stuff out and settle for a second. One really nice thing about doing vestibular rehabilitation is it's not a lot of fancy equipment that you need. And so the ability to incorporate that into your clinic is really quite simple. So you would need either a business card of some sort, or you could also utilize a tongue depressor with a letter on it, so 14-point font. And this tongue depressor is something I utilize when I do the VOMs. One of the aspects of the VOMs has them start to bring the letter in towards their eyes, and then you have to measure the distance. This is a really easy way to do that. But also, too, then you could also utilize it for vestibular rehab. So not too many extra pieces of equipment. And I like to use a tennis ball, but if you do not have a tennis ball, you probably have some type of ball in your clinic to play catch with a patient, which is a little bit different than when we normally play catch. So what I want to have you do is we're going to start off with gaze stabilization. This is one of the most basic starting points with your patients. You want your patient to be in a good seated position. A lot of times I will have them come in at a time that's not super busy in the clinic when we start. Because if it's super busy, I have a noisy environment, I have a lot of things moving about them, that may trigger some symptoms. So I try to schedule a time as best as possible. I know it's crazy in the high school setting at points. As best as possible for them to go ahead and do this with me in a more quieter environment. Maybe I have 1 or 2 patients in the clinic, but it's not super busy. When you put them on a chair, okay, when you have them seated, you have to think about what type of chair you have them on. You don't want anything that can swivel or moves or rolls or anything as best as possible because that can influence how they perform the task, or if they're not even noticing it and they're swiveling, that may make them more symptomatic. So we have to think about environment. This is a little bit different than some of the other rehabilitation programs you may utilize with your patients. We start small, but we have them do it multiple times a day. So this requires them doing some homework and being honest with you that they've actually done their homework. So you also have to make sure they are doing this correctly in your clinic before you go ahead and send them home to do that, because you want to make sure that they are not using accessory motions, they understand how they should be moving, and how the exercise is done. Now, some of your patients may not be able to hit that 20-second mark when they first start. It's okay to decrease that time a little bit. So usually the least amount of time that I will utilize is about 10 seconds with a patient. And then your goal is to increase time as well as some other progressions. So what I want you to do, so we're all going to do this together, is you're going to take whatever business card, whatever you're going to look at, and you're going to put it out in front of you. And you're going to pick one letter that's kind of in the center of the card to focus on. And so as you focus on this, you're going to move your head side to side. Now, most of you are probably healthy individuals, so before we start rocking out to it, a couple of things. If you start to feel symptoms, I ask you to stop. I don't need anybody feeling crappy for the rest of the day. So if you start to feel anything, I want you to stop. Small motions. So it's not this huge head turn in the beginning. It's about 20 to 30 degrees that I want the patient to be going. Okay? I want to be able to focus on that letter the whole time. And I want a nice, slow, maintained speed. You can also use a metronome to help with the speed of your patients. I like to kind of see how they kind of go in the beginning. All right, so are you ready? Because I'm going to time you guys. So we got our cards ready. Does everybody have their letter that they're going to focus on? Okay, I'm seeing some head nods. So now we're going to start side to side first. Focus on that letter and slowly move your head side to side. And try to be very fluent when you do it. I'm starting your timer. Okay, relax. What are some of the things you noticed doing that exercise? Before I start pointing out I will not point directly to the people I noticed doing it. I will just say general things. Anybody notice anything? Anybody notice anything from trying to look at the person next to them or maybe in front of them? Okay? One thing is, some of you had your cards down here. You want to try to have a nice, good alignment because we want to emphasize that, right? So if we walked around all the time in life like this, we'd get in a lot of trouble because we'd run into things, we wouldn't see people. Just like if you're out on the playing field, right? We don't want our patients out there looking at their feet the whole time. We want them to be able to look up and to look around. So again, make sure your eyes are nice and ahead. Some of you would pause. So you'd come here and you pause for a second and get yourself back together, and then you'd go. You want it to try to be as fluid as possible, okay? Some of you were really, really tiny. So sometimes what I will do with a patient is on the wall in the clinic, I will have kind of pieces of tape that are colored that kind of shows them the degrees I want their head to move. So sometimes that will be helpful if they're having a really hard time figuring out how much movement is needed. Okay? I didn't really see anybody moving yet, which is good because that's one of our exercises. So you guys are pretty straightforward. So the next one I want you to do is the same thing. I want you to put your arm out. I want you to focus on your letter, right? Your head moves, but your eyes stay focused on that target. Again, small. We're going up and down this time. All right, go ahead and begin. All right, excellent job. We feeling all right? I haven't seen anybody on the floor yet, so that's a good thing. So this is your most basic starting point with your patients. Things you can take your target and move it further back when the patient can. If the patient normally wears contacts or glasses, you want them to wear that when they're doing the exercise. For those of you who have patients who wear contacts, and glasses when they need to, they will find it and they will tell you, and probably from your own personal experiences, it's so much easier to be in a vision field when you have your contacts in because it moves with your eyeballs as opposed to your glasses, because you may go to look at something and you're like, whoa, okay, my lens is out, I gotta go back. So just being aware of that, you do want them to go ahead and utilize that as best as possible. It doesn't necessarily mean you have to conquer this exercise fully before you move on to others. So these may make your patients symptomatic, okay? So we have to think about when would we stop this exercise and when do we push the patient a little bit. Between them doing their different sets, okay, so I'm going to have them repeat this 3 times, I have them rest for about 30 seconds. Especially if they're symptomatic. If they tell me, hey, my headache increased a little bit, or I feel a little bit nauseous after doing that, I'm going to ask them to rank it, and I'm also going to monitor them for at least that 30 seconds and see how long it takes for their symptoms to start to decrease. Most of the time, these exercises, and with the card exercises, sitting, you may increase a little bit, but you're usually not going to have a huge spike in symptoms. If you have a person who's just looking and sitting there and they're like, my head really hurts, and they feel miserable, you're done for the day. You just know that they just couldn't take that load for the day, and you'll see them the next day. But you also want to ask them to monitor their symptoms throughout the rest of the day that they're not with you. When did they start to feel better? Did they start to feel better at all? Maybe they come in the next day and they still feel really crappy. Maybe 30 minutes later they felt better. So we're going to kind of gauge how much we can really push the patient. So that is the first exercise. Your next one, I'm going to test your coordination a little bit. So this is called a smooth pursuit. And in this exercise, again, you find your letter, you find your target, and what's different is you're moving your card, you're keeping your head not moving and straight, but your eyes are following that letter you've chosen. So I'm looking, I find my letter, my head and eyes are going to stay, right? My eyes are going to follow, my head's not moving, and I'm trying to be as smooth as possible. So why don't you go ahead and put your target up. I'll get ready to time, and begin. And go ahead and relax. Okay, what was different on that exercise for you? There's a little bit more laughing. I think we were looking at some other people, seeing what was going on. Patients here, things they tend to do. Stop, 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 or they come here. We want to try to get them to have that smooth pursuit as best as possible. If they are really, really struggling, what I sometimes do in the beginning is I will have them come, I will have them reset in the middle, and then I'll have them come out to the side and reset in the middle. That's if they are really struggling. Most of my patients have pretty good success that I could go ahead and have them do a nice smooth pursuit. This is where the metronome may be useful, just to kind of keep a more consistent pace. Things you don't want to see your patient doing is whipping their arm side to side trying to keep up. That's way too much. You can also, again, have targets, smaller vision field, working into a bigger field. So it all depends on what your patient can and cannot handle, what you're seeing from them. Right now, I'm having you guys do this for 20 seconds, okay? So not a huge amount of time, but still enough time that makes you think a little bit, kind of makes you do some of those things. The next one I want you to do is the same thing, but we're going to move the target up and down. So I have my arm's length about, I find my letter, my head, right? Head staying still, eyes are moving up and down. Are we ready? Go ahead and rock it. And relax. Okay, what we tend to see on patients with the up and down is that up is a small motion and down they tend to go really far. So again, trying to keep consistent in the field that they are working in. Again, you can utilize targets or just providing them some feedback. Again, using a metronome can be useful. You can, just like most apps, you could download a free metronome app so you can have it on your phone. And then the patient could also download it onto their phone so when they're at home they can kind of have that same environment as you. So when we are moving the card, we want to make sure we try to maintain a consistent speed and that we're kind of equal in the distance that we're moving. Again, if a patient's really struggling, we can pause them for a second in the middle and then go. You're just going to kind of have get a feel for that as you're working with your patient. So our next one has us moving our target, our head, and our eyes all in the same direction. So now I'm going to really see how coordinated you guys are. I have a great view of all of you as you get to do this, okay? So the next one is we move target, head, and eyes all in the same direction. So if I have my card out, all go together. So now what you are going to, I'm not even going to tell you what you may notice. I'm going to let you do that. All right, so card out, get your spot. Remember, your target, your eyes, and your head are all moving in the same direction. Go ahead, you're going side to side right now. Okay, go ahead and relax. What were some of the things you noted when you had to move all three things? Were any of you getting color blurs from the shirts around you? Okay, so now we're increasing the demand. We're putting more of that environmental stimulus there, so it is making it more difficult for our patients. Things you want to watch out for here with your patients is a lot of times you'll see their head won't really move, but their body will. So their head's going to follow their body, right? Because hopefully it's attached, otherwise we have a different issue on our hands. So you want to make sure that they're really working on moving their head and they're not cheating by moving their body. So this is where, if you only have a stool in your clinic, then you'd have them seated on the table because you don't want them to be able to swivel. So those are some things we look out for. So that, again, that is making sure everything's kind of moving in the same. So sometimes you may see them bring the target and then everything else. You want them to move everything as one unit. So sometimes this takes a little bit of practice with the patient because they have a hard time being coordinated enough to do it. So again, we're going to rest. We're going to ask them about their symptoms, see if we increase anything with them, and then we're going to just kind of monitor them from that time forward as we go. So the next one is the same, but we're going to move it up and down. Okay, so let's get our card. So our head, our target, and our eyes all move in the same direction. So it follows. Ready? Begin. And relax. What did you notice when you were going up and down now trying to move everything? So again, similar, some of the things I get to witness up here and what you want to watch out for with your patients is a lot of individuals will kind of go a little bit on the up and a lot on the down because that's more natural for us, right? Especially in today's technology world. How many times are we walking around and people are like this? Okay, so that is more comfortable and natural to them. So making sure they are going through that whole motion. Speed, right? Some of you, your cards were moving really fast, but your head and your eyes weren't going with it. So you want to make sure it's one solid unit. Again, being very mindful of that. Environment, okay, so the environment when we usually first start off is I will have them looking at something that's more blank, kind of more plain. So I usually have a spot reserved in my clinic that I can, if there's a poster there, that I can remove the poster and they have a nice blank wall to look at initially. As I progress them, that's one of my progressions, is I want them to look at a more busy environment. Because when they go back to their sport, it's not going to just be them out on the field or them competing. They're going to have a lot of other stimulus from the environment going on. Same thing with noise. I will incorporate noise a little bit further down the road with these individuals to simulate some of that, just to give them a little bit more to have to kind of tone out and to be able to focus with. So this is the tricky one. So this one, you're going opposite. So you're moving your target one way while your head's going the other way and maintaining your focus on that letter. So it's really important when your patient is doing this one that they're not doing some type of really huge movement in which you know they're absolutely not focusing on that letter. You want them to focus on that target still. So you're going to get your target. You're going to get your letter. So it goes opposite. So I'm here. I'm going to keep looking, keep finding that spot as I go. All right, so cards up. We'll see the coordination this morning and begin. So we want to try to be as smooth as possible. It's much more difficult with this one. And relax. We got to work on some coordination, right? I need to work on my coordination too. Don't feel bad. But the coordination aspect is a little bit more difficult. We tend to pause a lot more in this one because we're trying to see how much we can still see. So here when we start this one, I usually start my patients very small and then start to work them out bigger because I want to really emphasize that opposite movement and not that they're just making pretend with me, that they can really still focus on the target letter that they have chosen. Also speed, right? I need to make sure I can truly follow what I'm doing and not just stopping or not just moving fast and then trying to catch up at the end. So this does take some coordination. We all know that we may have some patients that aren't the most coordinated patients. So this exercise may prove to be very difficult for them. Okay, so now we got to go up and down. So opposites, right? Get your target. So as it goes up, you look down, and then opposite. All right? We ready? Begin. Go ahead and relax. Okay, so it's really important, right, that the goal is to maintain focus on the target and not just for them to move. So again, those smaller motions, I'm seeing some in the audience, right? We're getting these really, I'm whipping up and then I'm like, oh, I need to move my head down. Or they're putting their card in a spot where I'm not so sure you can really quite see the letter you're focusing on. So making sure we're trying to be as honest as possible, especially our patients, right, as they are doing these. Again, some patients may not be able to get to some of these points. So it's not like some of our other rehab protocols. So we think about an ACL protocol, right? There are certain things the patient absolutely needs to be able to do before they get back onto the field to play. With your vestibular rehab, what you're trying to do is improve overall symptoms. You're going to look at your VOM score. You're going to look at some of those other things. So maybe you did the dizziness handicap inventory. Maybe you did the ability to balance confidence scale. And you're going to see, are we making improvements? It doesn't necessarily mean they need to be able to do every single one of these exercises, because sometimes these exercises are too difficult and they just can't do it without being symptomatic. So you have to be mindful of that. So how do we progress these? Because it's not just, oh, I've conquered gaze stabilization, so I move on to the next point, especially knowing that some of our patients can't move on to the next point. So some of our progressions are here, okay? So, and we'll do a couple of these in a second, but I just want to kind of go over them first. One is standing with feet apart. Most of the activities our patients do, they don't do seated, so we have to start to integrate the other parts of their environment into their rehab protocol, just like you would do with any other injury. You would probably do a lot of different things with them in the clinic, but at some point you got to get them out onto the field or court and mimic a game situation. So I will have them start to stand up. Wide support first, then a narrow base of support. Have them start to do these things heel to toe. Maybe they're on an unstable surface, so maybe I'm using a foam pad or a Bosu ball or whatever I may have available in my clinic. And then I will have them marching in place as they do these exercises. So what you're going to do is you're going to pick, except for the foam, I don't have any foam mats for you guys, you're going to pick one of the progressions for yourself. So we're all going to be standing in a second. And you're going to, let's just do, you can do any of the exercises you want, okay? So you can do smooth pursuit, you can do gaze stabilization, you could do all the same direction, or you could do opposites. It's going to be your choice. But I want you to stand up. So if we could all stand up. All right, you're going to get your card. You're going to pick your poison. So it might be feet apart, it might be narrow base, it might be a tandem stance. You might be really brave and try to be marching when you do this. All right, so let's get our card out front. Remember, you're going to pick your card exercise, so either your gaze stabilization, your smooth pursuits, your same direction, or your opposites. Your choice. Are we ready? All right, go ahead. All right, go ahead and relax. We had a few brave souls out there marching. That was good to see. I got some brave souls doing some movements. All right? So these are things you can increase. So maybe my patient's doing really well with gaze stabilization, so I'm going to increase them doing that exercise to one of these modifications, but maybe we just started to do smooth pursuits and I'm still going to have them seated. So it doesn't mean everything has to progress at once. You're going to kind of have a feel for what your patient can and cannot do. Maybe day one, your patient is doing gaze stabilization seated and they're doing awesome, and that's not causing any type of symptoms. They're not having any problems with that. The next day, go ahead, have them just stand the wide stance and see what that does. Another thing you can do to increase the difficulty of these exercises is to provide a busy environment. And so that could be done a variety of ways. One is maybe they're doing some of these exercises while you have a lot of other patients in the clinic. Another could be you have some type of poster, that you can put up that provides a busy background. So not just a poster that says, maybe you have a poster that says, "I love my athletic trainer." That's a great poster, but it may not give them enough of that visual stimulus. So if you ever see some of those 3D posters where if you stare at it long enough, the thing comes out at you, now that may be too much. So something kind of in between there where it has patterns and colors and different things to kind of give them a lot more visual input that they need to go ahead and deal with. But also to be mindful that sometimes that really, really busy environment may just push them way over the edge. So it really is a lot of feedback from your patient as to what they have found to trigger their symptoms, and then also things to be helpful. But also, too, if they're having a lot of problems with some of the things, like they say, well, when I'm walking is when I feel some of these things the most. We want to make sure we try to get them to that marching point where we can do some of these lowers, especially that gaze stabilization while they are marching. So some more exercises. So these are our card exercises. These are things that really start to take the visual system and the vestibular system in a very much of a pretty controlled environment and starts to help that out and starts to make some of those connection back and hopefully with your patients decrease some of their symptoms. The next thing you would want to do, and you can do these as you do your card exercises, so it's not they have to graduate from card exercises to go to walking exercises. That's not the case. What it is you start to combine these things as you're working with your patients. And again, goes back to if they feel off balance, if they're having problems with gait. So one of the first walking exercises that we will do is have a patient walk to a target with their eyes closed. And so this is really important to think about your environment that you have them doing it in. So what do you think the differences are if I have somebody walk to a target with their eyes closed, if I have them in a big gymnasium, or if I have them in a hallway? What are some of the differences? Sound, okay? I have, size, right? So if I think about it's the middle of the night, you get up, you have to use the bathroom, you don't want to wake anybody in your house. You have a pretty good sense of where your furniture is from your bedroom to your bathroom, and even though it's dark, you could kind of maneuver your way around. But you might put your hand out because a couch or a wall or something is going to be there, so it gives you some feedback. Same thing as I see some of you saying wide versus narrow. Exactly. The gymnasium, if I put them in the center of the gymnasium, they're not going to get a lot of input from the walls around them. If I put them in a hallway and they start to veer to one direction or the other, naturally, most people are going to sense they're about to walk into something, and that's going to kind of guide them. So, do I have a volunteer? Anybody brave? Come on up. Okay, we're going to come over here, and so I'm going to show you some of the things, some of our general rules of when we have our patient walking. What's your name? Liz, thank you very much for coming over. We're going to come over here. And when I help Liz, I'm going to take my shoes off so she can't really hear them. So what I'm going to have Liz do is I'm going to line Liz up. She's going to pick a target across the way that she wants to walk to, okay? She's no moving targets, Liz says. Natalie. Oh, you're going to go to Natalie. All right, Natalie's not going to cheat. She promised me she's going to stay in her chair. Okay, so Liz is going to try to walk to Natalie. What I'm going to tell Liz to do is to focus on her target, and whenever she's ready, she's going to close her eyes and start to walk. But before we do that, so quick timeout, I'm going to walk with the patient, but I'm not going to be creeper, okay? Because if I'm right here on Liz, this is creepy, but also, too, she can sense where I'm at. But I'm also not going to be too far behind because if Liz is going to walk into something that could potentially hurt her, I'm going to make sure I stop her before she gets there. And I will simply tell you to stop, okay? So even when I have a feeling you're going to do great and get right to Natalie, I will tell you to stop, all right? So whenever you're ready, Liz, go ahead. Go ahead and stop. All right, so we were a little bit off course, right? Just slightly. That's all right. Liz volunteered. I'm proud of Liz. Okay, Liz, I'm probably going to use you for a couple other things if you're okay with that. All right, so one thing I want them to do is when they get to the point where I tell them to stop, if it's not their target, I want them to stop and stand there for a second and see where they went off. Things you will note in your patients. A lot of times, they may take a step or two to the side, and then they feel, okay, I'm going to the side, I'm going to correct myself. Well, they correct themselves with such pride that they start to do this quick diagonal, totally opposite direction than what they should be doing. If they get close to their target and you haven't told them to stop yet, you start to see them slow down and take more careful steps because they're afraid and they're not trusting you enough that you're going to let them walk in to whatever their target has been. So what we do is we start with different distances. So usually I like to start build a little bit of confidence, and get them to about a foul line or so on a basketball court, about that distance, and then start to build them from there as you're going with these walking exercises. They may have sometimes, if it is different surfaces they're walking on, so maybe you're working in a clinic setting and maybe you have some tile floor and then maybe you have some carpeted floor and they can kind of sense some of that. That's okay. Just you want to try to allow them to see that. Now, there are times where your patient will go, first time, they're walking to their target and they nail it. And they're like, I got this, I'm awesome. And then the next time you have them do it, whoop, they make a turn for the worse. So we want them to do it multiple times. I will have my patients do this at home if they have a safe environment to do it and they have somebody they can trust to guide them as they do that. Sometimes right at the college level when I deal with some of these patients, their roommates may be a little bit of a knucklehead and I don't really know if I fully trust them not to let them walk into things, so sometimes you have to pick and choose your battles a little bit. Okay, so that's one of your very first walking exercises. So Liz, if you could just come back up. I'll put my shoes back on. So that's another thing to think about is the noise. So if you're wearing shoes that make a noise or anything else, you would want to remove them so you have as much as a quiet environment. You guys did pretty good, but towards the end when Liz started to veer off a little bit, we started to chuckle a little bit because, no offense, Liz, but it's funny, okay, because people think they're walking the right way. You want to try to maintain that quietness as best as possible. So the only feedback they have is from what they are feeling. So how their feet are touching the floor, where they anticipate that they are in their environment. I'll just bring my clicker down, that'll be better. Okay, so the next one, I don't necessarily think we need to demonstrate this. I think we're pretty aware of walking heel to toe, okay? So again, things you want to keep in mind. Patient wants to keep their head up and looking forward. You don't want them to look at their feet. You want them to get that feedback from what's going on in their body. So we don't want to spend a lot of time with them looking at their feet. Eyes open first. That will be enough of a challenge for some of them. And then we want to progress them to eyes closed. Another goal would be get them to get to walking backwards. We find that in a lot of our patients who have dizziness and have some vestibular issues, that getting them to move backwards takes a lot longer. So when we start to move them backwards, they start to become really symptomatic. So you may need to hold off on that a little bit, or you may need to note that you kind of get to the point where they can only go eyes open as they move backwards. And that's okay, because you're still getting that into them. If you have an ARX balance beam in your clinic, you could also progress them to doing it on that type of a surface, or to, and I'll talk about this in a couple other slides, is that I will a lot of times go to Lowe's and just get a 2x4, and I'll use that for a lot of my different balance exercises because it's cheap, it's versatile, I can have different sizes, and it's just more budget friendly for me, but it does still do the trick for most of our stuff. Okay, so the next one I'm going to have Liz do, I'm going to grab my ball for next, is walking with head turns. So now we're taking some of the principles, and yeah, we could actually stay up here. We're taking some of the principles that we utilized with the card exercises, and now we're adding walking to the exercise. So the goal is for Liz, on her first time, is she's going to look to her right. She's going to take 3 steps, keep her head turned to the right. She's then going to bring her head back to the middle. It's going to 3 steps, and then look to the left and take 3 steps. When we come back this way, what we're going to see if Liz can do is if she could do it continuous. So I start them where I get them paused in the middle, kind of get their bearings back, and then have them look to the other side, with my main goal being from them to be able to look from one side to the other without a pause. So, Liz, if you could look to your right and start walking. So you're going to take your 3 steps. Now turn your head forward, right? Keep walking. Just keep walking. Good. To the left. To the forward again. She's modeling for you guys. To the right. Forward. And go ahead and stop. Okay, so the goal is that the patient is continuously walking, so it's not 3 steps, 3 steps. That's not the goal. The goal is that they can still continue to walk as they start with those head movements. So now Liz's goal this time, we're not dizzy or anything, right? No. Okay, wonderful. That's a bad look on a presenter if you do that. So Liz's goal this time is she's going to start looking at the left. She's going to take her 3 steps and then go right to the right and keep going. If your 4 steps are over, that's fine. If you could try to remember 3, awesome. If you're like, ooh, I'm off 1, that's all right. So she's going to start off by looking to the left. She's going to start walking after her 3 steps. She's going to look straight to the right without pausing. Yep. Okay, and relax. Much more confident in her catwalk this time. Right, you can give Liz a round of applause. She's doing great. She was one of 2 people who raised the hand, so I'd give her an extra round of applause. Okay, so that's the goal, is to get them doing that. So again, environment around you. Them being in a hallway versus them being in your clinic versus them being in a gymnasium. If they're an outdoor sport athlete, get them outside, get them out onto the playing surface doing some of these things. We want to try to bring that environment as best as we can as we are progressing them. So again, we bring some of these walking exercises in. Now what Liz is going to do is she's going to do the up-down look. So again, remember with her card, we had the patient moving their head up and down. Same thing with walking. So her first one is she's going to look up 3 steps, forward 3 steps, down 3 steps, back to that neutral position, and then on her way back, she's going to try to do it continuously. Whenever you're ready, Liz. And relax. Great job. Whenever you're ready, come on back, but we're trying to do it all in one motion. So no pause. Great job. So something that Liz did really well was she got a good amount of looking up. Sometimes, again, we see in our patients, they do this very little, but then a lot on the downward. So making sure that that motion is the same. So we want to make sure they're really looking up and that they're really looking down. Okay, and then this is a couple of different walking ball toss exercises. What's really important to emphasize here is that the patient is following the flight of the ball the entire time. So yes, most of us could probably play catch with a tennis ball at a short distance and not have to really focus on the ball the entire time and still be able to catch it and throw it to our target. The focus here is looking at the ball the whole time. So it's just like when we're doing some of the card exercises, it's a different type of eye tracking. We're still trying to make those connections and make those things come back. So we think athletically, right? If I have a softball outfielder, hopefully they're tracking the ball if it's coming to the outfield. We talked about the wide receiver in football. If I'm on basketball and I'm on a fast break, I need to be able to go ahead and look. If I'm further down the court than my teammate, I need to be able to look back and track the ball into my hands. If you have a soccer player or lacrosse player, they need to be able to control the ball with them and then be able to look around as to where they may need to go ahead and make their next pass or make their next move, or maybe they're taking a shot on goal. So they need to be able to do these things. So I'm going to have Liz hold the ball, and what she's going to do is the first one is tossing it up to herself. And so she's just going to start with one hand. She's going to toss it up, follow it, and then catch it and follow it down, and just keep as she's walking. I believe in you, Liz. You look a little scared. I have faith in you. And so with this, we can start small, and then when we get more confident, we can move to them tossing it up higher. Again, this comes a little bit to how coordinated is your patient. Thank you, Liz. Now this time what Liz is going to do is she's going to pretend she's in the circus and actually knows how to juggle, but with one ball. So she's going to start the ball with one hand, toss it, so it's going to be arcing motion to her other hand. She follows that flight of the ball into the other hand, and then she will come back to the other one. So if you could go ahead and do that. So arcing motion, she's going to follow it. Good job. Again, we're going to start with our patients a little bit smaller, and then we can, as they progress and do well, we could have them go ahead and increase the height at which they are throwing the ball. The other one is to work with a partner, and that is for them to throw the ball. So one partner will be walking backwards, one partner will be walking forwards. So can I have another volunteer? I don't trust my left hand this much. Can I have one more volunteer? Come on up. Thank you, John. Yep. All right, so does either one of you have problems walking backwards? I don't think so. Okay, well, we'll find out if you do. Okay, so they're going to play toss. John's going to start by walking backwards as Liz is moving forward. And they're both going to track the ball the entire time. So as Liz throws it to John, she's going to track it into John's hands. John's going to track it out of Liz's hands into his, and then he's going to toss it back to her. All right? So let's go ahead and see your guys' skill. And let's toss it a little higher. All right, and relax for a second. Great job. Now you're going to stay where you are, right? But you're going to just switch positions. So Liz is now going to be walking backwards while John is walking forwards. Go ahead when you're ready. So again, as I've mentioned before, sometimes your patients with vestibular issues or coming back from a concussion may have a problem with walking backwards. So great job, guys. Thank you. Go ahead and relax. Can we get a round of applause for both of them, please? We're training. You didn't think you'd be trained for the circus today, did you? I was making sure. Okay, yep, that's all I need you guys for. Thank you very much. So when you are doing those exercises, again, the person who's coming back may have a problem with walking backwards, so we would want to make sure that if that's the case, they're just walking forward. So whoever is doing the ball toss with them would be continuously walking backwards. That is a great thing. I like to incorporate their teammates as the person throwing the ball with them and not always me as the athletic trainer. Makes them feel like they're doing something with a member of their team. If there's time during a practice or if there's a drill where a player isn't really involved and they could come off and do that with their friend, or if you're in the clinic and they bring their friend in with them, or you tell them, hey, I need you to bring a teammate in tomorrow because you guys are going to be doing some ball stuff and you need somebody to play catch with. That has just worked out well in terms of a confidence boost for my patient that they're actually doing something with somebody other than me. It just makes them feel a little bit more part of the team at that time. Okay, so balance exercises. I know you guys are great and know a bunch of different balance exercises. So I've just put these up here to remind you that in your patients who have suffered a concussion, a lot of times we see balance issues. It may be something that they're complaining about. Please incorporate some balance training in with them. It's really important. You can start off, small and easy, and increase as you go with them. So you can see, so in my abbreviations, DL is double leg, EO eyes open. Okay, so then EC would be eyes closed, SL would be single leg. So it allows you to have some different neos. When they're doing the tandem stance, if they can't do the tandem, you could do a modified where they will then, instead of the back foot being a heel to toe, you could go ahead and have it where it's about at their arch, the medial longitudinal arch of their foot. So then still is going to provide more of a challenge, but they may just not be at the point where they could go heel to toe right away, and that's okay. So you can kind of bring them along that way. Foam pads, wobble boards, all those things are great. But I get it. Budgets sometimes are tight, and it's tough to be able to do some of those things and buy some of those things. So think about different environmental surfaces you have at your institution, so at your school. So if you have a track and you have a turf field right next to it, those are two different surfaces. So the track, right, is going to be more firm, where the field is going to be a little bit more giving. If you have a long jump pit, there's sand there. Have them do some of their exercises in that. So be creative with some of your environment, or if you're outside of practices and they're doing these things, it's okay to be in kind of what you consider more of a non-traditional aspect of where they are at. Some more balance exercises. You could do some trampoline ball toss if you have a trampoline. If not, ball toss with a partner is great as well. Or depending, you can utilize, if you have a cinder block wall in your office that is safe to throw a ball against, you could have them do some of that. I did learn that at one of the institutions I worked at, our one wall was considered like a false wall. So if you threw a med ball against it, it was not good. So I learned before I did, but that could have been really bad. I also really encourage you, if you're not already doing it, do some dynamic balance activities with them. So it's more than just putting them, get them moving and balancing at the same time. So again, if you have a trampoline, if not, if you have any type of cone reaches, if you do a modified version of the Star Excursion balance test, if you utilize 2x4s, as I talked about before, sometimes you just don't have the budget to buy some balance things, but if you can make some different kind of obstacles, I would say, with the balancing, then, just going to your local hardware store may be helpful. And if you can find somebody, I don't trust myself with power tools, so I always find somebody who I can trust, whether it's a coach or a colleague, or one of the maintenance people at school I have a good relationship with, and they will help me design a couple of these things. So it's a lot easier on the budget for some of those. So some of my take-home points is consider all the systems that may be affected by concussion. And so we do a really good job of diagnosing concussions now. We've gotten much better, and we're doing better at returning athletes to play. We have our 5-step protocol in most places, and so we're doing this graduated return to play. But the problem with our graduated return to play is that, one, if I have an athlete who's been out for 3 weeks with a concussion and their return to play is 4 days or 5 days, they've been out for 3 weeks. They've lost a lot of conditioning. So I need to take that into consideration. And maybe they need to not just have 1 day at every part of the step process. Maybe they need multiple days. So don't be afraid to be an advocate for your patient for that. Another thing is we're seeing these deficits. We're seeing balance deficits, right? So if I go ahead and I do the best test with them and they're all over the place, they have a lot of errors, well, did I do any balance retraining with them to make sure that anything that may have been affected has improved before I put them out onto the field? What have I done that mimics their game or practice situations in a non-harmful environment to help make some of these connections with their vestibular input? So some of this ball toss, right? We're doing it with a tennis ball, but then I can make it more sport specific. So then we talked about the softball outfielder. I could throw some of the ball to the softball outfielder, put them in their environment. The football wide receiver, basketball player. You can do these things. You can mimic these things. If you don't find yourself athletically coordinated enough,